where imaging is quite disappointing. The biochemistry of the urine is useful, and we now have a good correlation between the fetal urine and the adults that were managed like this in utero. This paper has been published in Prenatal Diagnosis last year. And the first author is Muller, Françoise Muller. So it was about nearly 850 cases of Luto. Then you just sort them out, as you've seen, the malformations, those without any problem that are really obstructive, like prune belly, high junction, and megaureter. Then those where you do shunting. So that's then those that you can follow up that were more than 10 years old. So we got to 100 of those survivors at more than 10 years. Mostly posterior urethral valves, but also high-grade reflux, and high-grade reflux really has the same prognosis as valves. They all had urine sample. And the correlation was with the gold standard evaluation of renal function, so glomerular filtration rate and the international classification for kidney disease, chronic kidney disease in stages. So you see that mainly when they had good biochemistry, they had a good renal function. And about 18% had a poor renal function. The other interesting finding is that when you get an evaluation at 10 years, it doesn't change afterwards. Now, you know that the fetal urine is hypoosmotic. It's hypoosmotic, and therefore you would look at those markers, sodium, calcium, phosphorus, and glucose, and the higher the values, the poorer the function. So we have set mean values here, and you can see that between an overall normal function and this abnormal function, the values were clearly different. And that is nearly independent from imaging. Imaging, unless you get a very dramatic picture like this one, where both kidneys are absolutely useless and you would have no fluid around the fetus. Otherwise, you get a mixed assessment of small cyst, and you don't know what to deal with. So if you have no fluid at all, obviously, you get very low glomerular filtration rate, and very few would pass the borderline of normality. But however, when the amniotic fluid is normal, it doesn't tell you anything at all. So these are the cutoffs that we considered in utero, and these have been the same cutoff for the last 30 years. And this is the sensitivity of each marker. So what is the most sensitive is actually a combination of beta-2 microglobulin and glucose. And this is the best sensitivity for a good renal function. For a poor renal function, therefore the specificity, this is chloride here and sodium. So if you get the whole profile, the whole biochemical profile of the urine, you can actually quite specifically determine what the renal function will be, definitely after birth, but also in the long term. Okay, this is slightly busy, but again, the paper has been published. So, and what we are hoping for is that those with intermediate values, not frankly abnormal, not really satisfactory, they may target the cases that you need to offer treatment for Luto. And treatment for Luto, as you've probably heard, at the moment, It's just a palliative treatment with shunting, vesicoamniotic shunting. Now, vesicoamniotic shunting, you probably heard that it didn't bring much in terms of results. If you have very severe cases, you put a shunt, you get a higher chance for this baby to survive. That is for sure. It's demonstrated. You die less if you get a shunt. But you don't know how you live, and especially the renal function. So the worst cases would survive with an abnormal renal function, and they would be candidate for renal transplant. But if you target those with a normal biochemistry, obviously they would not need a shunt. And those with probably the borderline urine profile, that would be the best population to try and offer a shunt. And very soon, probably endoscopy. You may have learned about endoscopy, cystoscopy, fetal cystoscopy to relieve the valves. Whatever you've read so far is wrong, in that the instrumentation is not yet ready for you to really ablate the valves, and that there is a technical obstacle to get to the valves. And what people have done so far, including us, when we think we've got the valves, 9 out of 10 we don't hit the valves. We hit the posterior prostatic urethra, and at best, into inverted commas, you create a fistula between the urethra and the perineum. So it's not great. So at the moment, shunting is the thing to do because it does increase survival. But we need to better refine those candidates for shunting so that you don't create survivors with renal transplant in the early infancy, but you really protect the kidneys that are on the verge to become abnormally functional and hopefully preserve the renal function. In any case, this urine analysis in the fetus seems really predictive, both the sensitivity and the specificity for adulthood. So it's worth setting. It's not fancy genetics. If you agree with a biochemist and this biochemist reads that kind of papers, he will be able to set the standard of his machine so that it's adapted to the concentrations of very low concentrations of sodium, chloride, and glucose, and beta-2 microglobulin in the urine. Do you have questions on this?
Chị có câu hỏi nào không? Chúng ta có một cái update về việc đánh giá chức năng thận trong những cái đối tượng mà có bế tắc đường niệu dưới bẩm sinh. Phép chắc tóm tắt lại chút xíu để cho các anh chị ấy thì những cái quan trọng nhất để chúng ta bắt đầu tất cả những chuyện này như là thầy đã nói, đó là chuyện đầu tiên chúng ta cần phải có một cái lab để cùng làm việc phát triển cái con số reference cho cái chúng ta làm, chứ không phải là chúng ta muốn chọc hút cái gì đó rồi chúng ta gửi đến một cái lab nào đó cho một bất kỳ hôm nay gửi lab này, hôm sau chỗ đó không nhận nữa gửi lab khác, thì tất cả những cái con số đó nó không đồng nhất, chúng ta không biết được cái cách phát triển và chúng ta sẽ không thể tiên lượng được. Đó là chuyện đầu tiên chúng ta phải làm, và tất cả những kết quả này dựa trên cái công trình nghiên cứu trong suốt bao nhiêu năm trời của François Muller, là người đứng đầu tại Paris. Người ta làm trên thai tại Pháp với tất cả những con số như vậy. Tất nhiên sau khi người ta đã chuyển sang cái reference của người ta, do đó là chúng ta chúng ta sẽ còn rất nhiều việc phải làm trước khi mà chúng ta dám ứng dụng tất cả những chuyện này. Tuy nhiên trong thời gian hiện tại thì chúng ta có thể xem thấy rằng là những mặt cơ của phân tích nước tiểu thai ở đây thì người ta thấy rằng là nó giúp cho chúng ta được một cái chuyện là phân ra thành nhóm rất xấu và nhóm rất tốt. Như vậy thì còn lại ở cái nhóm ở giữa là cái nhóm mà chúng ta có thể phải suy nghĩ đến can thiệp bào thai. Vậy thì cái can thiệp bào thai như chúng ta thấy giáo sư phân tích là từ cái lần thứ hai, từ section thứ 2 đã nói chúng ta chưa sẵn sàng trên thế giới về việc là nội soi bào thai để giải phóng cái bế tắc này. vì những cái chưa hoàn hảo của việc phát triển dụng cụ, chúng ta có thể sẽ làm nên một cái tình trạng là dò mặt sau của cái ống niệu đạo đó xuống dưới cái phần tầng sinh môn thôi, chứ không phải là chúng ta giải phóng được bế tắc. Vậy thì đó chính là những cái thai tiềm năng để chúng ta đặt sinh. Chúng ta cứu sống được nó, nhưng chúng ta phải cứu sống nó một cách đáng. Chúng ta phải chọn lựa ra được những cái đối tượng mà thực sự đáng sống, mà vẫn còn cái cơ hội sống lành lặn với một cái chức năng thận tương đối tốt, chứ không phải là vừa mới sinh ra chúng ta tạo ra một em bé sống nhưng mà sau đó nó phải chịu ghép tạng ngay. Nhất là khi ở Việt Nam thì rõ ràng chúng ta không có ghép tạng ngay lập tức ở sơ sinh với em bé như vậy. Vậy thì sau cái bài tổng kết này, các chị có câu hỏi nào về chuyện bế tắc đường niệu dưới cũng như là những cái can thiệp bào thai hay là những cái đo đạc này hay không ạ?
Em muốn hỏi một chút là với bây giờ thì đây là nghiên cứu, chắc người ta sẽ lấy luôn khi lúc đặt săn. Còn nếu mà theo cái này thì mình sẽ cần làm một cái xét nghiệm trước khi để mình quyết định đặt săn hay không. Vậy thì lúc đấy mình sẽ lấy ở đâu? Lấy mẫu nước ối và bao nhiêu tuần?
32 tuần.
Thế tức là những cái ca mà nó sớm hơn thì mình sẽ không lên được.
There's a question regarding to the optimal gestational age to be sampling.
From 16 weeks onwards, the value is the same. From 16 weeks onwards, up to third trimester. We have, there's another paper in prenatal diagnosis that we've published the analysis of the urine at different gestational ages. From 16 weeks, it's the same values.
Cái bảng phát triển đó chúng ta thấy là nó từ 26 của François Miller, nó từ 26 tuần trở lên đến 36 tuần là có một cái slide nào đó thể hiện như vậy, và cái trung bình nó khoảng 32 tuần. Nhưng mà vì người ta có cái reference như vậy trải từ 26 trở lên thì chúng ta có thể làm, người ta có thể làm như vậy. Nhưng nó tương đối tương quan, nhưng mà tương đối nó cũng đồng nhất với lại một số các nghiên cứu trên thế giới có cái reference làm từ 16 tuần. Chứ còn cái nghiên cứu gốc của François Milan, nếu các bạn xem lại những cái slide trước, nó bắt đầu trải từ 26 tuần đến 36 tuần.
And it can be the bladder or the kidney, whichever side. Because there have been stories about stagnant urine in the bladder, and therefore tapping first, waiting for that to fill up, tapping again, doesn't change a thing, same thing. Okay. Now, the last piece is arrythmia. So I'm not a cardiologist, and this is usually explained by cardiologists, and I would strongly encourage you to make friends with your cardiologist and find at least one who is interested by the fetus, because they would do great work, and especially for that kind of topics, not only for malformations, but for functional cardiology. In any case, there are two nodes. Although we don't get the QRS of the fetus, if you replace the depolarization nodes on this scheme, this is the auricular node, and when it starts depolarizing, the P wave is the auricle depolarization. And then this space, the PR space, is quite important, because it tells you if the second node, the auriculoventricular node, is going to respond or not to the depolarization of the auricle. If it does work, then this is a fixed, sort of a fixed distance. And if it doesn't work, then this PR is going to increase. And there are ways to assess it in the fetus without having an electrocardiogram, obviously. And then that would get you to the bradycardia and the AV blocks. Now, this is the depolarization of the ventricle, the QRS complex. And this then lead to a time of repolarization of the ventricle. So this complex, unfortunately, we don't have access to outside research in the fetus and especially in the human fetus, but this is a critical node in terms of allowing for tachycardia whenever there is a dysfunction in the auricle. So all those tachycardia that will be triggered by the dysfunction of either this auricular node or the auriculoventricular node. If it's this one, the origin will be auricular, and that would be mainly the flutter and the errant auricular tachycardia. And this would trigger the most frequent supraventricular tachycardia, which is the junctional tachycardia. But then you will have accessory network like the HIS that could trigger proper isolated ventricular tachycardia or reactivate through an abnormal pathway those nodes into a dysfunctional mode. So a normal cardiac heart rate is in between 120 and 160, and if it works well, you have a one-to-one conduction here on the M mode between the auricle and the ventricle. And this is variable, so this is not a fixed frequency, as you know from obstetrics as well. Below that is bradycardia, and above 160 is tachycardia, but then above 200 is tachyarrhythmia, and it is severe tachycardia that needs to be dealt with, because that is when you cross 200 that there is a degree, even mild, but there is a degree of myocardial cardiac insufficiency, and there you can get into hydrops and fetal demise. And the same applies to tachycardia. It can go down to 50-60. 50-60 is still, it's a cutoff. If you go below that, there is a cardiac arrest and cardiac insufficiency and irreversible damage also to the brain because it's not pumping that much. So arrhythmia can be benign, and that's the extra systoles. And these can be very benign, or they could foresee the development later on of tachycardia. So there are simple extrasystolic, auricular extrasystole that would trigger a ventricular response, and there are some that are bigeminate, and those bigeminate you can see very often when you do a 20-week scan. That happens in about 2-3% of fetuses. This is completely benign, but those again, they could lead to fetal tachycardia, so it is a good practice if you see that at 20 weeks to ask for a check 4 weeks down the road. And those bigeminates, if you don't pay attention to their transient and characteristic features, then you could make falsely the diagnosis of bradycardia, because after the second one there's a blockage and no ventricular response. Start with tachycardia. The classification from what I showed you on the anatomical drawing, the most likely, nearly 70% of them are junctional. So it's supraventricular tachycardia, and the most frequent within the supraventricular tachycardia is the junctional with a reciprocal rhythm, so 1-to-1. And then you've got some specific atrial polymorphic where the auricles go sideways and the response by the ventricle is very variable. And you've got the flutter, and a flutter is a very fixed periodicity between tachyarrhythmia of the auricle and the ventricular response, and usually it's 2-to-1 or 3-to-1. Ventricular tachycardia is much less frequent, and the monomorphic ones are usually iatrogenic or in reaction to fever or endocrine dysfunction in the mother. So that's the series. I will show you the results later on of this series, but the flutter are of particular importance because they can be quite resistant to the usual pharmacology. And I showed you yesterday an example where this went into high drops early in the third trimester, resisting to all therapies, and we had to do a invasive procedure in order to override mechanically and electrically to override this flutter. So this we could do for a flutter, but it would work very poorly for a junctional and the supraventricular junctional tachycardia, because these junctional tachycardia usually involve reactivation, intrinsic reactivation from the ventricle, and you could actually stop the tachycardia. We've done that 2 weeks ago. Same context, but junctional tachycardia, not flutter. It stopped immediately, went back sinusal. 1 hour later, it was back in tachycardia. So this does not happen with flutter. Flutter is difficult to stop with the pharmacology, but if you stop it mechanically, it doesn't recur. Where junctional tachycardia usually respond well to pharmacology, but then they recur. So junctional tachycardia, there's a one-to-one transmission between auricle and the ventricle. And it is reactivated by an accessory network. So you can calm that down mechanically, but it would recur. And you have to impregnate the mother and therefore the fetus with a very consistent concentration of anti-arrhythmic drugs so that you remain below the dangerous cutoff of 200. But it's very rare that it does resolve completely before birth. As for the flutter, will also be a video. Yeah. Oops. No. Right, was supposed to be a video. Well, the essential here, it's ugly here, but the essential bit here is to realize that the frequency of the auricles is different from the ventricle. And you see that on the M mode, but if you realize that, you will have either a complete dissociation between the auricles and the ventricles, and that's a polymorphic atrial tachycardia, or you will have a periodicity of 2 to 1 or 3 to 1, and that's a flutter. Ah, yeah, here it comes, see? So this is a 2 to 1. And the polymorphic atrial tachycardia, there's a complete dissociation between the two. So the auricles just go bananas here, and the ventricle would react very episodically. But since it's very rapid, it still appears as a tachycardia, even on the CTG recording neighborhood. By the way, those, if they have that at the time of delivery, we do cesarean sections. We tried about 20 years ago to monitor them with saturation, O2 saturation during labor. But I think the effort is not worth doing because there are probably other incidents during labor that is not resumed to oxygen saturation, for which the strength of the myocardium is probably necessary for this fetus to do well. So we just do cesarean sections for those now. We don't try to monitor them non-invasively. So pragmatically, if you have that is those you need to care about, those with a ventricular frequency of over 200 beats per minute. If the auricles beat at the same speed as the ventricle, this is a junctional one. Usually, if you try the treatment I'm going to show you, you can manage to keep them under 200. If they go over 200, it depends then on the gestational age. If you are already above 35 weeks and there are signs of high drops, just deliver them prematurely, electively. If you are at less than 35 weeks and there is a development of high drops, then you can try to inject directly the digoxin into fetal circulation or the flecainide. The risk is a cardiac arrest. And there's not much, we don't use verapamil anymore. We don't do that, or striatin. We try to avoid the striatin, which is a very violent stop in the heart rate. But we would go for a mechanical stimulation even if we know it's going to recur. If the auricles beats quicker than the ventricles, if it's regular, it's a flutter. A flutter, you will have more problems to maintain it below 200 with the pharmacology only, and it's a good candidate to mechanical and electrical direct stimulation in utero. If it's completely irregular, it's a polymorphic tachycardia, atrial tachycardia, and usually those do not go into high drops, so it's not that much of a problem. So it is quite useful to know what the mechanism is in order to predict the success or failure and the permanence of success or failure. The most important thing is to make sure you don't reach to high drops stage, and also that you don't have overt cardiac insufficiency with a massive regurg at the level of the tricuspid or the mitral, because then that would indicate some degree of myocardial insufficiency. And it is also useful to prepare the mother to get the treatment. So she should receive an electrocardiogram herself, a complete ionogram, and the thyroid workup. And the drugs are those you know. Digoxin, the oldest, goes well through the placenta if there is no high drops. If there is high drops, you go for flecainide because it crosses the placenta nicely, even with high drops. The surveillance for the mother, they are dealing with the level of the drugs in the blood and the ECG. Amiodarone, well, it's sort of a last shot, because once you've started amiodarone, you cannot change anything anymore. So you're stuck with it, and the only thing left, you cannot add any other drug to that, and the only thing is then to go for a mechanical or electrical direct action. Sotalol we don't use on the first line, but the Americans do use that usually on the first round. It's a beta blocker, so you have the potential consequences for the neonate of the beta blockers, and therefore we do try to avoid that. So our protocol here, if it's a supraventricular tachycardia without hemodynamic failure, we give digoxin only, usually 3 tablets a day, but it depends on the maternal concentration. If it resists for 10 days, we usually go by 10 days. If it resists for 10 days, we add flecainide, same posology, same surveillance. If we have eye drops, we keep the we skip the digoxin alone. We go for flecainide plus digoxin, knowing that digoxin is mainly useful if there is a flutter. And if that resists, then you go for cordarone, for amiodarone, but you stop the digoxin and the flecainide because amiodarone doesn't cope with anything. The interaction is too toxic. And they've been intrauterine death with the association of the two. When you start those, if you start amiodarone less than a week after you've stopped the others. And usually you just follow, you carry on with the treatment. This is the American recommendation. So in case of high drops, they would use flecainide and digoxin. They put sotalol top of the round for everything, but we don't because of the side effects in the neonates. So there is not much contradiction. And then you have this escalate up to direct fetal treatment with intramuscular digoxin. We don't do that. We don't do that. We prefer now to move to a direct stimulation as shown yesterday. And this is the series that we've got. So if you get severe hydrops or moderate edema, the majority of cases do come back to reduction, but that is only overall in 60 to 70%. So 30% of those babies are born electively prematurely. And in case of severe hydrops, see that the mortality is not negligible still. But the earlier we deliver them is 32 weeks, because it is rare that you have to act before that, except for that case of a flutter I showed you. But with no hydrops, there is no mortality, and they usually reduce either by themselves or because of the treatment in the majority of cases. Bradycardia now. So I will left aside the long QT. It's usually a familial condition. Important to recognize in the family, so if you have fetal bradycardia, you should send this woman to a cardiologist, because her life is at risk if she's got long QT. She could have an anesthetic accident and not cope very well with the delivery. So it's more a sign to explore the mother. And a good cardiologist could look at that by measuring the PR and suspect eventually a long QT also in the fetus. So the auricular extrasystole, blocked extrasystole we've dealt with, it's a differential diagnosis, not bradycardia. And then the auriculoventricular block is the problem. So if there is a history meaning a previous child, or history meaning the woman has got an autoimmune disease, especially lupus, with anti-Rho and anti-LA antibodies, so SSA, SSB, then she's a high risk. You could look at the fetal PR. To look at the fetal PR, you do a Doppler at the junction. You should have the mitral valves, and you should have within your range also the aortic outflow. And then you can measure the PR here between the atrial contraction and the beginning of the ventricular contraction. If it's a long PR, so you have normal ranges, if it's a long PR, then there's a risk there for that to evolve into atrial ventricular block. If you get to that stage, you should also be very careful to look at the cardiac anatomy, because the worst prognosis is that if you have atrioventricular blockage plus cardiac malformation, it's a very poor prognostic factor, even for very benign or so-called benign cardiac defect like a VSD. It could be AVSD, and it could be also single ventricle outflow, or more complex cardiac malformations. But the big question here is that then the fetus very often reveals a maternal pathology that was unknown, and this is really when to dig and find out if this woman has lupus or isolated presence of anti-Rho, anti-LA. So the incidence in pregnancies of those is about 3%, but if there is a atrioventricular block, it raises up to 70%. And it's important for those because there is a recurrent risk from one pregnancy to the other of about 1 in 5. The mortality is far from negligible, and more than half of these babies will need a pacemaker, and some of them will also develop cardiomyopathy. So this is a serious, very serious concern. So the first degree of after a long PR is a second degree AV block, and the second degree AV block leaves at least a conduction of 3 out of 4. But if there is a complete dissociation between the auricles and the ventricles on the bradycardic mode, then it becomes a third degree AV block. this third degree AV block is going to go to high drops in about 80% of the cases if it starts before 30 weeks, and it does start before 30 weeks, because the antibodies cross the placenta from 15 weeks, from even 12 weeks onwards. So those with dramatic history, they would show a dramatic picture as early as early second trimester. These are the British recommendations. So if you have AV block, you would check the mother, anti-Rho, anti-LA. Negative, then these are the least dramatic, usually. If it is positive and there is a previous child, the risk for this one, as we've seen, is about 17–20%. And there is a regular follow-up, about once a month, for those. Although, yeah, once a month here. If there is no previous history, sort of same thing, and you can be a bit more loose every 4 to 6 weeks. If you got a 2-to-1 AV block, so from grade 2, you would need to consider dexamethasone. So again, dexamethasone is to be balanced with the side effects, but you would give, I think, about 4 milligrams a day, and see if that stopped the evolution from a second degree to a third degree AV block, because this one would very often go to high drops. Then you're in trouble, because if high drops is there, dexamethasone is unlikely to work, so you have an advantage to pick up those cases very early and maybe over-treat rather than run after it, because once it's there, even the salbutamol or the hydrochloroquine would not really make any difference. If there is no fetal high drops, you just observe until the heartbeats go below 50. If it goes below 50, even without high drops, treat. And often, if the gestational age is compatible with a good survival, deliver. The one I showed you yesterday after intrauterine death and this complete AV block with high drops at 30-something, we decided that when he was beating at 40 per minute, we decided that we would do an exit and put the temporary pacemaker while the baby is still on the placenta, and then move to the theater, because sometimes they don't even reach the operative theater, which is 100 yards from the delivery room. So, conclusions. Supraventricular tachycardia, know about the mechanism. Always treat. Can start with digoxin and see the escalate. Be aware of high drops. These are the only ones that can die, but they can die. And if there is high drops, you need to get a quick response, either pharmacologically with flecainide or mechanically with the direct electrostimulation. For bradycardia, for the AV block, make sure there is no lupus, or if there is lupus, be generous in your indication for treatment to prevent the passage to a third degree, because once in the third degree, you're stuck. You're stuck for either watch it die if there is high drops, or maybe an exit with a pair delivery pacemaker placement. And definitely those need to be delivered where exactly they can get the pacemaker placed as early as when they're not born yet. Questions?
Không có ai có câu hỏi nào sao? Trời, mọi người chưa tỉnh ngủ hả? Các bạn có câu hỏi nào không vậy? Tại vì thực ra lupus trong thai kỳ cũng khá. Chúng ta có thể gặp nhiều, mà nhiều khi chúng ta chỉ quan tâm đến chuyện là gửi đến bên thận hay bên thận để đánh giá thôi. Rồi thận người ta cũng chỉ nhìn cái thận mẹ thôi, chứ người ta cũng không nhìn gì cả toàn cảnh. Do đó là khi chúng ta học chuyện này thì chúng ta sẽ là cái người để mà cố gắng đưa lái cho bệnh nhân đến từng chỗ một. Chúng ta gửi bệnh nhân đến thận thì chúng ta cũng phải gửi bệnh nhân đến tim.
Dạ, em có một cái câu hỏi là trên cái bệnh nhân mà có tiền căn là sanh con block AV mà có kháng thể bất thường á, anti-SSA dương tính hay gì đó, thì cái lần tiếp cận sau khi họ mang thai á, là mình có làm cái gì hay không, có điều trị dự phòng mặc dù biết nguy cơ tái phát cao, hay tức là có làm một cái gì khác ngoài cái chuyện mà tầm soát tới khi phát hiện bệnh là điều trị không ạ? I have a question that if a pregnant woman that has previous baby with a block AV and positive with anti-SSA or SSV or LA positive, so what can we do when dealing with that pregnancy?
Well, as I showed you, we do see them every month. We look at the cardiologists look at the PR, even with a normal heart rate. He looks at the PR. If the PR space is increasing, can't remember the normal range, but usually above 40, 80 milliseconds or something, then you consider treatment to be ahead of problems. Especially, did you say she had a previous child?
Yeah.
Well, definitely we would give her dexamethasone.
So right after conception, or so when should we start?
The antibody starts crossing the placenta at 12 weeks, so
Yeah.
you would start very early.
Yeah.
Yeah.
So we start on dexamethasone for prevention.
Yeah. But then, you know, you can be exposed to the side effects. So these babies then, because of the lupus and because of the dexamethasone, nearly all of them are growth restricted.
Yeah. And so when we follow up until the second trimester and didn't see anything, so
You,
in that
you
case,
follow them up to delivery, yeah?
Yes.
And because they are growth restricted, these ones, they exceptionally go beyond 36 weeks anyway.
Yeah. Thank you.
But it gets worse usually after a first accident. It gets worse the next time. So not to be missed. Yeah, you can't waste one.
We have seen many cases that has PUV posterior urethral valve syndrome. They go very early in the first trimester, and then when they go at 16 weeks, we already seen the dilatation up to the pyelectasis. So when we do the fetal urine biochemistry, you puncture to the
After the bladder, directly the bladder.
Yeah.
Doesn't matter. But those first trimester cases usually are not posterior urethral valves. In 90% of the cases, they are atresia, urethral atresia, or the severe stenosis. So the prognosis is not the same at all. Or it can be prune belly for another reason, sort of hygienisis of the abdominal muscles or whatever could be behind, but it's very rarely posterior urethral valves seen in the first trimester. That's why their prognosis is not that good, and it's also about 30% of them have got chromosomal abnormalities. So if you see a megacystis in the first trimester, it's a strong indication for a full karyotype or even array, because it's a good provider of chromosomal problems.
Yeah.
I have now an ongoing pregnancy with a bad history. The woman during her first pregnancy, the woman was finished with stillbirth due to severe iuria, and it was diagnosed as lupus, systematic lupus. And now she get pregnant again at now around 6 weeks, and right now the current treatment she has now is prednisolone prescribed by I think nephrologist, Do you think methylprednisolone consider as well as good as
No, it doesn't, because it doesn't cross the placenta.
Okay.
So you have to use, I think, dexamethasone if you want the placental impact and the fetal impact. I don't think prednisolone transplacental passage is sufficient.
And how about
Well, I should check about that, but I don't think so.
Yes, but you're right, because there's only two corticoids that pass the placenta, is betamethasone and dexamethasone. But how about the using methylprednisolone and dexamethasone during pregnancy?
Yeah, I mean, the mother will have massive side effects, but yeah.
And it's positive, the SSO, SSA,
Yeah. If they cannot replace prednisolone for her, if they cannot replace it by hydrochloroquine, for example, often they give hydrochloroquine to these women, so you can use dexamethasone without adding too much. I mean, these are massive doses of steroids, huh? So she will have really significant side effects.
She was being treated by hydrochloroquine just before getting pregnant, but after knowing that the nephrologist stopped this treatment and switch
It goes from one internal medicine person to another one. They got different recipes, but hydrochloroquine, apart from also being a risk factor for IUGR, I don't see, between this and having massive doses of steroids, I'm sure it's either the plague or the cholera, but it's not very different.
Tôi có cần tóm tắt lại không ạ? Cái ca mà tôi đang hỏi thầy đó là một cái ca thực tế hiện thời đang khoảng 6 tuần. Tuần trước tôi gặp cô là sợ cô có bầu lại lúc 5 tuần, thai vừa mới cấn bầu. Lần trước nữa cách đây khoảng chừng 3 tháng 4 tháng cô thai lưu vì thai chậm tăng trưởng nặng ở khoảng chừng 28 tuần và được chẩn đoán là lupus ban đỏ hệ thống. Kỳ đó chẩn đoán rồi, xong rồi sau đó thì cô được theo dõi liên tục, ca của Vi đó, theo dõi liên tục với lại bên thận, thì bên thận họ biết rằng có thai thì họ ngừng cái hydrochloroquine vì họ sợ liên quan đến thai, họ chuyển sang methylprednisolone. Thì tôi có hỏi là nếu mà bị như vậy thì tôi có dám xài thêm dexamethasone hay không, thì thầy trả lời là bắt buộc phải xài nếu như chúng ta có chỉ định, bởi vì methylprednisolone thì nó không qua nhau, và chỉ có dexamethasone thì mới qua nhau để bảo vệ được cho đứa con, trái tim của đứa con. Nhưng mà như vậy thì khi sử dụng hai thứ cùng một lúc thì nên xem xét lại cái chỉ định là quay trở lại cái thuốc kia điều trị ban đầu, thay vì là bây giờ như cái cách mà thận đang xài là methylprednisolone, bây giờ mình đã chỉ định thêm dexamethasone cùng một lúc nữa thì có thể là cái side effect nó sẽ rất là kinh khủng đối với cái người này. Các anh chị có những cái chia sẻ lâm sàng nào khác không ạ?
Em chỉ muốn hỏi một chút là nếu mà mình đã dùng hydroxychloroquine rồi thì sau mình có nên dùng tiếp dexamethasone nữa không?
Như cái cách thầy nói đó là chúng ta sẽ dùng tiếp, tại vì cái đó nó chỉ xài cho vụ lupus thôi, chloroquine thôi, còn cái dexamethasone mới là cái mà để bảo vệ trái tim em bé, đi qua nhau và bảo vệ trái tim em bé. Tại cái ca của anh đó là bác sĩ bên thận á, khi họ biết có thai thì họ sợ, họ dừng cái kia lại và họ xài methylprednisolone. Mà bây giờ mà anh chỉ định thêm dexamethasone, tỷ dụ như chút sắp tới mà ở 12 tuần mà mình đã nhìn thấy có chuyện gì mà mình có chỉ định dexamethasone thì mình xài hai cái đó một cái. Thì đó bây giờ làm sao?
Yeah, I was just checking. There's a very useful website in France called the CRAT, C-R-A-T, You should connect to this one as often as necessary. It's very well maintained, and it looks at the interaction of any drug with the pregnancy and breastfeeding. It's a national website, and it's really good. It's in French, but so hydroxychloroquine crosses the placenta, same concentration in the fetus and in the mother, and the state of knowledge are very many observations, very common and very reassuring. So there is particularly no ophthalmologic toxicity on the fetus. So those who are already on hydroxychloroquine, they should not stop it during pregnancy. They should carry on with this. And this is updated in 2018. So irrespective of the gestational age, they can be on hydroxychloroquine.
Thầy vừa mới chia sẻ cho chúng ta một cái dữ liệu, một cái ngân hàng dữ liệu về các cái chất, về các cái report mà có thể việc sử dụng thuốc có thể gây nên tình trạng teratogen hay không á, thì có một cái dữ liệu của Pháp là cái ngân hàng Luto. Các bạn sẽ đánh chữ LE là LE.
C-R-A-T. You type CRAT, drugs, pregnancy, it will show up immediately.
Và như vậy thì các anh chị sẽ thấy trong đó là hydroxychloroquine nó không có cho đến năm 2008 và có rất nhiều dữ kiện nói rằng là nó không có ảnh hưởng gì đến thai cả. Để chắc là trường hợp này chắc tôi phải đi kiếm lại bên thận để đòi xài lại.